Vanakkam. Is tuberculosis rare? Do we see cases of tuberculosis affecting the hand and upper limb even today? Yes, we do. Tuberculosis can affect the hand and upper limb in many ways. It can affect the skin, it can affect the tendons, the muscles, the bones, and even the joints, and in different age groups. Of course, tuberculosis is going to affect mainly patients who are malnourished or who are immunocompromised. But even otherwise healthy patients do present with manifestations of tuberculosis affecting the hand. In what ways is the hand affected and what is the treatment for these conditions? We shall see in this video. Tuberculosis is still a major public health burden. In 2019, approximately 10 million people were infected by tuberculosis globally, and out of these, an estimated 1.4 million became symptomatic. Tuberculosis can present in pulmonary and extrapulmonary forms, and musculoskeletal tuberculosis accounts for up to approximately 30 to 40% of extrapulmonary cases and 1 to 3% of all tuberculosis cases. We can classify tuberculosis affecting the hand and upper limb into 4 forms: cutaneous tuberculosis involving the skin, tuberculous dactylitis involving the fingers and the finger bones, tuberculous tenosynovitis involving the tendons and muscle units, and tuberculous arthritis involving the joints. Cutaneous tuberculosis is nearly always caused by the Bacillus Mycobacterium tuberculosis rather than the other variants. Involvement of the skin could occur either by direct inoculation of the tubercle bacilli into the skin, or spread to the skin via the bloodstream, or even extension into the skin from an underlying infective focus. There are 5 described forms of cutaneous tuberculosis: tuberculosis verrucosa cutis, lupus vulgaris, scrophulosderma, miliary tuberculosis, and orificial tuberculosis. And as far as the hand and upper limb involvement by cutaneous tuberculosis is concerned, the first 4 categories will be discussed. Tuberculous verrucosa cutis presents as purplish or brownish red warty growths, and these lesions most often occur on the knees, elbows, hands, feet, and buttocks. This form of involvement is usually self-limited and usually involves mainly the hands in adults. These lesions can get secondarily infected, and if excision is done, it must be done under anti-tuberculous therapy cover. Lupus vulgaris presents as small, sharply defined reddish-brown papules which merge into plaques with a gelatinous consistency, sometimes known as apple jelly nodules. This type of lesion is a persistent and progressive form of cutaneous tuberculosis. They may persist for years, leading to disfigurement or even skin malignancies. Scrophulosderma is usually a firm, painless lesion which ulcerates and has a granular base, and it's typically seen on the neck. It can also present in the limbs, and these lesions may heal even without treatment, but may take many years to do so and leave unsightly scars. Miliary tuberculosis, of course, represents the late form of tuberculosis when the disease has spread throughout the body. The skin lesions in such a condition are small, millet-sized red spots that become necrotic, developing into ulcers and abscesses. The patient is generally sick and prognosis is poor because many patients die even if diagnosed and treated. The entity of tuberculous dactylitis was described by many people. Boyer gave the anatomical description and called it spina ventosa in 1803. Nelaton proved the etiology as tuberculous in 1837. Rankin identified tuberculous dactylitis by histological technique, and Filchenfeld described tuberculous dactylitis on X-ray in children in 1896. The term spina ventosa is classically used in tuberculous dactylitis. Spina means short bone and ventosa refers to expanded with air. This is because tuberculous dactylitis affects short tubular bones, mainly the phalanges and the metacarpals. This affects children more than adults. In fact, 85% of patients with tuberculous dactylitis are less than 6 years of age. A study showed that incidence among children with tuberculosis was reported to be 0.65 to 6.9%. In tuberculous dactylitis, the bones of the hands are more commonly affected than the bones of the feet, and among the bones of the hand, the proximal phalanx of the index and middle finger are most commonly affected. In children, multiple bones are involved, whereas when this condition presents in adults, it is usually a single bone that is involved. This usually has a clinically benign course without pyrexia or acute inflammatory signs. So the common presentation is a painless swelling of a digit of a few months duration. Short tubular bones have a lavish blood supply through a large nutrient artery entering almost in the middle of the bone. The first inoculum of infection is lodged in the center of the marrow cavity, and the interior of the short tubular bone is converted gradually into tuberculosis granuloma. This leads to a spindle-shaped expansion of the bone, which is classically described as a spina ventosa, with the occlusion of the nutrient artery of the involved bone. This leads to destruction of the internal lamellae. In natural course, the disease heals with shortening of the involved bone and deformity of the neighboring joint. Plain radiography is the modality of choice for evaluation and follow-up. Bones distal to the wrist are usually affected by tuberculous dactylitis. In this example from literature, the X-ray shows a cystic expansile lesion of the third metacarpal. The margins are well defined with internal septations and associated cortical sclerosis. There is cortical destruction but no periosteal reaction. So the characteristic features of tuberculous dactylitis on X-ray are a diaphyseal expansile lesion with uncommon periosteal reaction. Healing is usually by sclerosis, which is a very gradual process. This shows another classical example of tuberculous dactylitis from literature. This condition will often recoup itself with anti-tuberculous therapy. Surgical excision and curettage may be required in some patients with large lesions. Anti-tuberculous treatment will consist of 2 months of 4 drug therapy followed with 2 drug therapy for a period of almost 1 to 1.5 years. Tuberculous tenosynovitis refers to involvement of the tendon sheaths and the synovium surrounding the tendons and subsequently the muscles and the joints. This involvement could be due to direct extension from adjacent bone or joint infection or hematogenous spread from a distant primary focus. The infection appears to start in the synovium and then gradually spreads to the tendons and even the bones. This tuberculous tenosynovitis seems to selectively target the area of the wrist and sometimes the volar aspect of the hand. The main setback remains the difficulty in diagnosing this problem because of non-specific clinical signs. The differential diagnosis could be pyogenic infections, brucellosis, foreign body tenosynovitis, sarcoidosis, rheumatoid arthritis, or de Quervain's disease or ganglion. On X-rays, a soft tissue swelling may be seen with or without calcification, and in chronic cases joint space narrowing and osseous erosions may be seen. MRI may show thickening of the synovial membrane, increased vascularity and fluid within the tendon sheath, or reactive inflammation and swelling around the tendon. This differentiates it from acute suppurative tenosynovitis, where synovial sheath fluid is the predominant feature. In tuberculous pathology, there is very little synovial sheath fluid. Fine needle aspiration cytology is the mainstay of investigations for such a suspected swelling of tuberculous tenosynovitis, which may show a granulomatous pathology. The classical finding on exploration of such tenosynovitis would be what are known as rice bodies. These were described first in 1895, which are nothing but intrasynovial masses resembling rice grains. They are caused by synovial microinfarction followed by synovial shedding and further encasement by fibrin. Tuberculous tenosynovitis may appear in different forms depending on the duration of the disease, the varying resistance of the individual and varying virulence of the organism. Generally, tuberculous tenosynovitis is gradual with progressive swelling, pain and diminished range of motion or even total loss of motion. There have been three described stages. The hygromatous form, where there is a serous exudate within a normal appearing tendon sheath. The serofibrinous form, where the rice bodies appear in the synovial fluid and involvement of the tendon itself with granulation tissue is seen. Intertendinous adhesions or complete rupture may occur in this form. The fungoid stage involves extensive caseation and granulation tissue formation. There may even be a sinus tract or a cold abscess formation. For understanding the different stages, I usually classify tuberculous tenosynovitis into three clinical presentations. One is when they present as a swelling either on the volar or dorsal aspect. Second, when they present as a swelling with decrease in the range of movements, either flexor or extensor. And finally, when they present with total loss of movements of some fingers. When they present as a swelling of the hand on the palm, which may extend to the distal forearm, it is usually known as a compound palmar ganglion. This is because cross fluctuation exists between the swelling on the palm and the swelling on the forearm, which are communicating under the flexor retinaculum. When they present as a swelling on the dorsal aspect of the wrist, they may mimic a ganglion, but these swellings are usually soft in consistency. They involve the tendon sheaths, and while excising them, we must take care to avoid injury to the tendon sheaths. We will note that there is a granulomatous mass which must be excised without injuring the tendons or the nerves. Sometimes swellings can present with decreased range of movements either in the fingers or in the hand. For example, this 25-year-old male presented with the complaints of swelling in the right hand and inability to flex the ring and little fingers fully of 2 months duration. On examination, there was a soft swelling on the palm extending from the ring finger up to the forearm. There was a reduction in active range of flexion in the ring and little fingers. MRI showed the soft tissue swelling around the flexor tendons of the ring finger. These are the zigzag incisions that were made for the exploration of this swelling, and this shows the incision completed in the palm. The skin flaps were then raised on both sides to expose the entire swelling in the palm and finger. The exposure has now been completed. Taking care to protect the neurovascular bundles and the flexor tendons, the pulleys are opened and the granulomatous tissue around the tendon is gently excised. The tendons are laid bare, and after protecting the nerves and the superficial palmar arch at the proximal aspect of the palm, the incision is made into the forearm by incising the flexor retinaculum. The granulomatous mass is excised from the forearm and the wrist regions also. This is the situation after excision of the granulomatous mass and making sure that all the tendons are intact. We can see the protected and preserved the pathognomonic histological feature, that is, the Langerhans giant cell, was seen in the biopsy specimen. Postoperatively, based on the biopsy report confirming the evidence of tuberculosis, anti-tuberculous therapy was started. Alongside, physiotherapy also was started and this was the status at the end of 3 months. Sometimes the patients may present with total loss of movements of the fingers either on the flexor side or on the extensor side due to rupture of the tendons. This 70-year-old lady presented with the inability to flex the thumb at the interphalangeal joint, the index and little fingers. She also had a swelling on the flexor aspect of the distal forearm. This was the marking made to explore, and this was the excised specimen, which was the granulomatous mass surrounding the flexor muscles, and this specimen also shows the ruptured tendons, the flexor digitorum profundus and superficialis of the index and little fingers and the flexor pollicis longus. This lady had a swelling on the dorsum of the wrist for the past 5 years, but she did not undergo any treatment for the same. For the past 1 month, she has noted that she is not able to lift the index finger. This shows a rupture of the extensor tendons of the index finger due to the tenosynovitis involving the tendons. The MRI shows features of extensor tendon tenosynovitis. The treatment of tuberculous tenosynovitis involves the following 3 options: medical management, surgical exploration and biopsy, and reconstruction of tendons. Medical management could be medical management alone for a patient presenting with tenosynovitis in whom the FNAC has proved that it is a granulomatous lesion, possibly tuberculous. Medical management can also be started following surgical debridement and based on the findings on surgery and the histopathological report. Surgical exploration and biopsy is usually not the first treatment of choice, but it is indicated if there is a negative FNAC, if there is a large swelling with pain or restriction of movements, MRI shows muscle or tendon involvement, or there is an obvious rupture of the tendons. The procedure of surgical exploration involves a liberal incision to expose the entire musculoskeletal system, finding granulomatous tissues surrounding the muscles and tendons with multiple rise bodies. Excision of the granulomatous tissue is very important, though it may not be completely possible. Most of it can be debulked. In patients with complete rupture of the tendons, either flexor or extensor following tuberculous tenosynovitis, reconstruction of the tendons can be done, but this should be done only when the primary disease is burnt out with medical management. As far as tuberculous arthritis is concerned in the upper limb, studies have shown that Mycobacterium tuberculosis infection of the upper limb joints is quite rare. Of the involved joints, the elbow is most frequently affected joint in the upper extremity, consisting of 1 to 5% of all cases of skeletal tuberculosis. The commonest mode of infection of the elbow joint is by hematogenous spread from primary focus of infection elsewhere in the body, usually the lungs. The features of such an involvement of the elbow are pain, swelling, gradual decline in the range of movement of the joint. There may be cold abscesses or chronic sinuses that point towards the diagnosis. A cold abscess is an abscess with the absence of classical features of inflammation such as pain, redness, and increased local temperature. Chronic cases may present with sinuses in about 1/3 of the cases and joint deformity. Undermined edges, bluish discoloration at the edges with serous discharge, and fixation to the underlying bone are the classical features of a tuberculous sinus. The presence of a sinus is an important clinical feature of tuberculosis, as other infections rarely cause such sinuses. The tubercular sinus may communicate with the elbow joint or lymph nodes and may present on any side, the posterolateral, lateral, posterior, or even the medial aspect of the elbow. The lymph nodes, that is the epitrochlear, supratrochlear, or even the axillary lymph nodes may be affected. Destruction of articular cartilage occurs late in the sequence of the disease. The radiographic changes of tuberculous infection are quite non-specific. We will be able to see periarticular osteoporosis, osseous erosions, and gradual narrowing of the joint space, and these three together constitute what is known as the Phemister's triad. Transphyseal spread of the infection to the joint is one of the hallmarks of tuberculosis, though the joint space is relatively preserved in early tuberculous infection. In the elbow joint, the most commonly involved bone is the proximal ulna, followed by the distal humerus and finally the radial head. There is another pathognomonic feature that is sometimes described as the ice cream scoop lesion, which is an expanding cystic lesion in the proximal ulna metaphysis with its subsequent erosion. This was described by Agarwal A. et al. In 2010. These osseous erosions arise due to profuse pannus formation and granulation tissue within the joint. This video shows the exploration of a chronic sinus on the elbow. Here we can note after splitting the biceps tendon, there is a granulomatous mass and further incision revealed a cold abscess. This cold abscess was found to be communicating into the forearm deep to the flexor muscles. This was also drained. Since this surgery was done under anti-tuberculous therapy cover, this wound would definitely go on to heal well. Tuberculous arthritis can also affect other joints of the upper limb, like the wrist. This 52-year-old man has had treatment for pulmonary tuberculosis 25 years back and again 10 years back when he had a relapse of the tuberculous infection in the lung. He developed multiple swellings on the left forearm and hand. He also complained of pain in the wrist. X-ray revealed involvement of all the carpal bones, lower end of the ulna, radius and the lower end of the metacarpals in this tuberculous involvement of the left wrist. As far as tuberculosis of the hand and upper limb is concerned, we need to keep tuberculosis as a working diagnosis in any lesion or swelling on the hand which does not conform to the classical diagnosis available. Tuberculosis can present in many forms in the hand, and early diagnosis and management are the key to successful treatment of the condition. I hope you enjoyed the video. Please do click on the shown links to see more about other surgical procedures in hand surgery. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.